So I think there were a couple of variations on what you just described, and let's kind of deconstruct that. If we're talking about the acute coronary syndrome, I was especially struck by one particular trial. The nomenclature is irrelevant, but it's the early BAMI trial. These investigators very astutely said, can we revisit the administration of intravenous beta blockers in the setting of an acute myocardial infarction, a STEMI, if you will, and demonstrate that there is unique advantage in the PCI error, because we need to remember that although we respect greatly the importance of giving intravenous beta blocker therapy for patients who present with acute myocardial infarction, all of the evidence to support this benefit were collected in the pre-PCI state. And even those data points, I actually remember them well, were at best modest, not definitive. And so now when this strategy is revisited in the PCI era, there's no appreciable advantage of the early administration of intravenous beta blocker. Now, that does not negate the benefit of oral, chronic, longitudinally administered beta blockers post-MI, but it does raise the question about whether or not there's a practice that we continue to do for historical reasons only that couldn't be put in a sunset mode. So that was interesting. I don't think we're ready to act on it vis-a-vis guidelines, but we certainly are more aware that perhaps it's not as beneficial. And certainly if there's any concern that a patient is at risk for bradycardia or heart block, I would think there's no reason to give the intravenous beta blocker regardless. The other thing that I thought was very interesting, staying now in the ischemic heart disease space, but stepping away from ACS, is that we saw the 10-year follow-up data from the STITCH trial. And this too has been recently published in the New England Journal of Medicine by Velasquez and colleagues. And it demonstrated that out to 10 years, we clearly see evidence of a survival advantage for surgical treatment of multivessel coronary disease and reduced EF heart failure versus medical treatment. Remember, the original STITCH data said there really wasn't any difference at the first primary endpoint review. Subsequent post hoc analyses did give us some insight that perhaps STITCH wasn't quite as neutral as we thought. The surgery might have an advantage, but perhaps in those with the lower ejection fractions, with the larger ventricles, and with multivessel disease. But that's not enough to really act on clinically. But now that we've seen the 10-year data, and there's been enough time to overcome the initial morbidity and mortality of surgery, the signal does appear. Now we should be cautious and not trumpet these data too much, because of the entire cohort, 75% of those that were in the surgical arm were dead at 10 years, and 85% of those in the medical cohort were dead at 10 years. So it tells us all that the treatments for chronic ischemic heart disease, whatever they might be, are not sufficient to really sustain life in a manner that we would feel would be most appropriate. But at least we can appreciate that if indeed the patient has suitable targets and the surgical team has an acceptable risk profile, that whenever possible, surgery for reduced ejection fraction multivessel disease ought to be considered as a treatment for those that have heart failure due to coronary disease. So this was interesting information, but with a number of caveats that I've outlined. We can take this one step further and think about structural heart disease. It was exciting to see two different analyses, PARTNER 2, especially in the SAPIEN 2 data, to tell us that it is quite likely now that we can extend the benefit of TAVR into the intermediate risk population. It is at least non-inferior, which means it is just as good as, by a statistical margin, just as good as surgical intervention, and perhaps in some of the observational data, it might be superior. And if we look at the PARTNER 2 data and the transfemoral access, again, perhaps it might be superior, but we started off thinking about TAVR essentially in those that had a prohibitive surgical risk. And then we saw benefit in those at a high surgical risk, and now we've moved that window to an intermediate risk. Does that mean the future is one where aortic valve replacement for aortic stenosis will predominantly be a percutaneous cath lab-based procedure? Certainly there are certain versions or idiotypes of aortic stenosis for which TAVR is not suitable, like bicuspid aortic valves, aortic insufficiency, those kinds of other substrates. But nevertheless, to see this field progress like it has progressed really is not evolutionary, but revolutionary. Striking difference from the way we used to approach aortic valve disease just about a decade or so ago. So if we go on to the heart failure specific domain, we've reacquainted ourselves in the realm of disappointments. That has usually been what we've seen in heart failure, with the exception of the remarkable data addressing the combination of valsartan and sacubitril and the important data addressing ivabradine and its associated benefit. But at this meeting, we saw the data now in the Atmosphere trial using a direct renin inhibitor, aliskiren, compared to enalapril or compared to placebo or aliskiren plus enalapril. We just didn't see a benefit. And so that tells us that this alternative way of disrupting the RAS system is not superior to the conventional approach, which is ACE inhibitors. And we remember that the predicate literature already identified a risk of aliskiren, and particularly in the diabetics, of accelerated or more significant renal disease. So another lesson learned, that even though we respect that activation of the renin-angiotensin-aldosterone system drives the pathological syndrome of heart failure, it depends on how you modify that system. And in this case, using the direct renin inhibitor is not the right strategy. Shines yet another light on the remarkable data using the combination of valsartan and sacubitril. We also saw data at this meeting addressing another way of modulating neurohormonal tone in heart failure, this time using a vagal nerve stimulator in about 707 patients. These data, unfortunately, were not rewarding in the sense that it was not a positive activity. Now, we did understand that it was done safely. That had been a concern before. But we also recognize that over and above evidence-based medical therapy, there were few, if any, advantages. That's important because that tells us yet again that when we consistently, correctly, and appropriately administer evidence-based, guideline-directed medical therapy for reduced EF heart failure, patients do very good. In fact, that's a pretty high bar, and it's very hard to do any better than that. So that's another important message that's a take-home. There were some other smaller studies that raised some interesting hypotheses looking at devices to look at lung water, not so certain how much we should embrace that information, looking at vitamin D and determining whether or not it's got an effect on reverse remodeling. Again, not so clear, having looked at both databases, how much we should embrace those data points. But it's great to see that there's still more research activity going, but it validates and confirms that the right thing to do is what we know to do right now. Follow the guidelines, deploy evidence-based medical therapy. And I think I go back to the beginning. Think about preventing heart failure. I'm most excited about the fact that we can probably fundamentally change the natural history of developing heart failure by modifying the risk factors. And then once you get disease, I think we have many, many more tools now than we ever had before. And so we can truly tailor a program unique for each individual patient with heart failure and target best possible outcomes. So in a final analysis, I think once again, a national meeting like an ACC meeting or American Heart Association meeting really does one of several things. It brings new information to the table, it endorses what we already know, and it opens up new questions worthy of pursuit. So it makes it a success.